This review is all about the roadmap for subarachnoid hemorrhage SAH management. We'll cover the classic clinical features, the non-negotiable 6-hour CT rule, and the very specific blood pressure targets that define urgent intervention. So let's jump right in.
Okay, let's start with the basics, just for clarity. What is the precise definition of a subarachnoid hemorrhage?
Fundamentally, it's bleeding that occurs in the subarachnoid space.
Yeah.
That's the area between the brain tissue itself and the membranes that envelop the central nervous system. A very important space because that's where the major cerebral vasculature sits. And when this bleeding happens spontaneously, what's the most frequent cause we see in the emergency setting?
The overwhelming majority of spontaneous cases, maybe 85%, are from a ruptured cerebral artery aneurysm, a catastrophic rupture.
So that's the main thing to look for.
Absolutely. But we also have to rule out other causes, things like arteriovenous malformations or other rare incidents. But the immediate priority is always the possibility of an aneurysmal rupture.
So when we're taking a history, what are the high-risk patient factors that should immediately raise our suspicion?
You're looking for things that compromise vessel integrity. So a personal or family history of cerebral aneurysm, severe or uncontrolled hypertension, and certain genetic disorders like polycystic kidney disease.
Okay.
Any history of previous vascular lesions, that raises a red flag right away.
The urgency here is immense. Can you quantify the risk if the diagnosis is delayed or even missed?
This is probably the most sobering statistic. If the initial SAH is misdiagnosed or missed, the fatality risk can be as high as 50%.
50%.
Yes. And that reality drives every single step of the rapid clinical pathway we're talking about. It's an emergency where a misdiagnosis has legal consequences.
Given that terrifying fatality rate, time is everything. How do we recognize that absolute hallmark presentation?
Well, the presentation is usually unmistakable as long as the patient can describe it. It's the sudden, severe, explosive, thunderclap headache.
The worst headache of life.
Exactly what you'll hear. They consistently describe it that way. It's not a headache that ramps up, it's instant.
And how fast does that pain get to its maximum intensity?
Maximum intensity is reached almost instantly, usually within 60 minutes, 1 hour of onset. That rapid escalation is the key thing that differentiates it from other headaches.
If a patient says it went from 0 to 10 in 5 minutes...
You have to treat it as a subarachnoid hemorrhage until proven otherwise.
Now, that bleed can sometimes be triggered. Are there any surprising physical triggers we should know about?
Yes, absolutely.
Yeah.
Clinically, we often see it initiated during moments of sudden increases in blood pressure.
Like exertion.
Exactly. Heavy lifting, straining, or, and this is an important one, during or immediately after orgasm. That's a key piece of history to ask about.
And beyond the pain, what other symptoms should we be looking for?
Look for signs of meningeal irritation. So neck pain or stiffness, neutral rigidity is common. Patients might have some transient altered consciousness, photophobia.
Sensitivity to light.
Right, or nausea and vomiting from the pressure changes. In more severe cases, you might see focal neurological deficits or a rapid decline toward coma.
There's also a very specific physical exam finding that can point to a localized aneurysm, isn't there?
There is. It's a third cranial nerve palsy. This shows up with an ipsilateral pupillary dilation. So the pupil on the same side is dilated.
And what does that tell us?
It's a powerful clinical sign.
Yeah.
It strongly suggests the aneurysm is located at a specific spot, likely the posterior communicating artery, and is physically compressing the nerve. That demands immediate vascular imaging.
We also have to talk about precursor events. What are sentinel bleeds and why are they so dangerous?
Sentinel bleeds they're essentially warning shots.
A smaller leak before the big rupture.
Exactly. They are smaller, self-limited leaks from the aneurysm that can happen days or even weeks before the major hemorrhage. They present as a milder, sudden headache.
Which could be easily misdiagnosed.
And they often are. As a migraine or a tension headache, the danger is that it's a missed opportunity. It signals an unstable aneurysm that is going to re-rupture. You just can't afford to miss it.
Okay, let's move to the diagnostic pathway. What's the absolute mandatory initial test?
The first-line test, no question, is a non-contrast head computed tomography, a CT scan. It's fast, it's available, and it's highly sensitive for acute blood.
And this brings us to that famous clinical rule. What is the critical time window for a negative CT to confidently rule out a subarachnoid hemorrhage?
The window is 6 hours. 6 hours from symptom onset.
Okay.
A non-contrast CT done on a modern scanner within those 6 hours if it's negative. It essentially rules out SAH. The sensitivity in that acute phase is just extremely high.
But patients often present late. If someone comes in after that 6-hour window and the CT is negative, what's the required next step?
Right, so if you're outside that 6-hour margin, the sensitivity of the CT starts to drop. The blood breaks down. So a negative CT after 6 hours is not enough.
So you have to do more.
You must proceed to one of two options, either a lumbar puncture, an LP, or a computed tomography angiography, a CTA.
Let's talk about the lumbar puncture first. What's the thinking there?
With the LP, we're looking for evidence of blood breakdown products. Specifically, we're looking for something called xanthochromia.
The yellow discoloration of the fluid?
Exactly. It's from bilirubin, and it takes several hours to develop. So if the CT is negative after 6 hours, the LP becomes highly sensitive for confirming that blood was there, even if it's cleared for the CT view.
Got it. Now, what if the initial CT is positive? You've confirmed the SAH. What's the immediate next imaging test?
Once SAH is confirmed on that first CT, you immediately get a CT angiography, a CTA.
And what does that show you?
The CTA maps out the cerebral vasculature. It evaluates the exact size, location, and shape of the aneurysm. This allows the neurosurgery or neurointerventional teams to immediately start planning how to secure it.
Diagnosis complete. Now, stabilization. What is the primary management goal at this stage?
The goal is preventing rebleeding. And that means you need an immediate and urgent consultation with neurosurgery or a neurointerventional team.
Because they have to secure the aneurysm.
Right, through either surgical clipping or endovascular coiling. Your job is to stabilize the patient for that procedure.
One of the most important interventions is blood pressure control. What is the specific target for systolic blood pressure?
It's a tightrope walk. You have to reduce the re-rupture risk, but also maintain enough perfusion to the brain. The guideline is to keep the systolic blood pressure strictly below 160 millimeters of mercury.
160.
Below 160, that's the target.
And which medications are preferred for hitting that target safely?
You need short-acting titratable agents. Labetalol and icardipine are most commonly used. They're effective and have a rapid onset and offset.
Are there any blood pressure meds we should specifically avoid?
Yes. Avoid any agents that risk increasing intracranial pressure. So specifically, avoid nitroprusside and nitroglycerin. They can paradoxically raise intracranial pressure, which is a disaster here.
Okay. Beyond blood pressure, we have to worry about delayed cerebral ischemia from vasospasm. What medication provides neuroprotection?
The required agent is nimodipine. It's a calcium channel blocker given to reduce the likelihood of a severe neurological deficit.
And what's the dosing schedule?
The standard protocol is nimodipine, 60 milligrams administered orally every 4 hours. It has to be initiated quickly and maintained rigorously.
And what about patients who are on anticoagulants like warfarin?
That is a life-saving reversal. You must stop and immediately reverse all anticoagulants and antithrombotic medications. Ongoing anticoagulation just dramatically increases the risk of the hemorrhage getting worse.
Finally, what about seizure prophylaxis? Should that be routine for every patient?
That's a bit more of a controversial point. Patients are at risk for seizures, for sure, but routine universal prophylaxis. The evidence isn't definitive. It's often reserved for patients with clear risk factors or who have already had a seizure. So, to synthesize these key points, remember that instant, severe thunderclap headache. Adhere absolutely to the 6-hour CT rule. If it's confirmed, get that urgent consult and start strict blood pressure management, aiming for a systolic below 160. And start nimodipine every 4 hours.
And that level of adherence is what separates a good outcome from that 50% fatality rate. Your ability to recognize the symptoms, understand the limits of the CT window, and implement that immediate stabilization. That's what saves lives.
And as you go forward, consider this final point, those sentinel bleeds. The fact that they exist means that any patient who presents with a sudden severe headache, even if the symptoms improve or seem mild, cannot be dismissed. If you're past that 6-hour CT window, you must complete the workup with a CTA or a lumbar puncture. Always suspect the worst to achieve the best outcome.